Just raise your hand if you can hear me. Just raise a hand, please. Julia, can you hear me? Oh, she's gone. Okay, everybody can hear me. So, hi Cesar, thank you very much for joining. Can everybody hear? So I want to say good morning and welcome to our live breast cancer tumor board this morning, and a special thanks to the doctors presenting our cases. Unfortunately, Dr. Yanin Shavari from Mexico City hasn't yet joined us, so she wants to present the first case. So we're going to ask the Philippines, if that's all right, Hody. We're going to start with the second case, which is the case from Philippines, and then if Dr. Shavari joins us, we'll go back to case number 1. So we'll start this morning with case number 2. I want to say thank you to both Yanin, who isn't here, and Dr. Anna Karina de Jesus and Dr. Hurdy Glorianne Luna from Manila in the Philippines. Thank you for joining us. And Dr. Valev from Sofia in Bulgaria. Thank you, Dr. Valev, and your colleagues. And I also want to extend a special and warm thanks and welcome to our panelists at MGH in Boston, myself, Professor Alphonse Tagian, Dr. Susan Sadro, who will join us, and Dr. Michelle Specht. Dr. Carol Marquez from Stanford University, Dr. Jeffrey Weitzel from the City of Hope in California, Dr. Jack Urban from Tufts Medical Center, Dr. Jean Wright from Johns Hopkins University, Dr. Julia Chu from University of Pennsylvania, Dr. Seema Khan and Dr. Cesar Santa Maria from Northwestern University in Chicago, Dr. Charlotte Gale Patterson from the Cancer Surgery of Mobile, Alabama, and Brittany Bashkovsky, medical oncologist from Dana-Farber in Boston. And I also want to extend a warm welcome to all our viewers who are viewing this live tumor board today. Just a quick housekeeping rule. Please keep your microphones on mute while you are not speaking, so everybody can participate comfortably in the tumor board. We need just the people speaking. When you want to ask a question during the discussion period, feel free to turn on your mic, obviously. And with that in mind, I'd like to welcome Dr. Hurdy and her colleague from Manila in the Philippines to present our first case of this morning, which is actually, as I said, our second case on the file. So, Hurdy, can you hear us?
Yes, Dr. Goss.
Okay, great. Whenever you're ready, and please be near your microphone, turn it up a little bit. Thank you. We're going to share the slides, and this is case number 2. Jessica, I might ask you to present as well, because I'm looking around and I can't think it all. Okay, please go ahead, Hurdy.
Hey, good morning. I'd like to present the first case. This is the case of a 42-year-old female premenopausal with no known comorbidities, has no family history of cancer. She's a Gravida 2, Para 2, and she denies any intake of oral contraceptive pills or any herbal medications. It was in the second quarter of 2015 when she felt a palpable left breast mass with eventual progressive enlargement and ulceration. During this time, the patient also noted a palpable axillary lymph node. And on the fourth quarter of 2015, an excision biopsy of the left breast mass was done, which revealed an invasive ductal carcinoma measuring 1.9 by 0.7 by 0.6. The skin was positive for tumor, and the subtype was ER/PR negative and HER2 positive. She eventually underwent modified radical mastectomy of the left breast, which revealed invasive ductal carcinoma, Nottingham grade 3, with a tumor size of about 3.5 cm in the greatest diameter. The axillary lymph node and the skin and nipple areola complex were positive for the tumor. Margins were negative. And on the first quarter of 2016, the following workups were done. The CBC and creatinine were normal. The alkaline phosphatase was noted to be elevated. Total bilirubin were within normal. However, the SGOT and the SGPT were found to be markedly elevated. On imaging of the liver, it was found to be normal. and 2D echo and checks X-ray were unremarkable. The bone scan requested was not yet done during that time.
Purdy, can you try to put the microphone just a little bit farther away from you? We're getting a little bit of feedback.
When you're ready, please go ahead.
And during that time, we gave the patient liver supplement, but upon repeat laboratories, it was noted to be progressively elevated, about 11 to 13 times above the upper limit of normal. We did hepatitis B and C screening, which turned out to be negative. And during this time, we referred the patient to a gastroenterologist. Our diagnosis is invasive ductal carcinoma, left breast, stage 3.
Yeah. Purdy, sorry to interrupt. Are you using a microphone and a devices? Hello?
We'll try to
Hello?
cut down the feature.
Hello, sorry.
Yeah.
Poor audio. We're getting some echo feedback from the phone, but if you have an individual speaker, could you place that farther away from you to see if that can help?
Purdy, can you continue, please?
Okay. Our diagnosis would be an invasive ductal carcinoma of the left breast, stage 3C, 84, N3,
Purdy,
M3.
sorry to interrupt. We can't hear you very well. Can you put the microphone closer to you, please?
ERPR negative, HER2 positive, and there's a note of transaminitis with possible autoimmune etiology. Our initial plan was to give an adjuvant chemotherapy with a taxane-based regimen. However, clearance from a gastroenterologist was not granted. And we also plan to give adjuvant radiation therapy and adjuvant trastuzumab therapy here. However, in our patient, there is a noted hepatic dysfunction.
Purdy, let me ask the question for you. Just if you mute your microphone, Purdy. Okay, thank you. Let's go back to the discussion. Okay. So the first question is, this patient received adjuvant chemotherapy with doxorubicin and docetaxel, but it says clearance was not granted from the gastroenterologist. I'm not sure what that means. And then adjuvant radiation and neoadjuvant. So this is a patient locally advanced stage 3, HER2 positive.
Can everyone please mute your microphone?
Can you mute your microphones, please? So the first question is, what is the optimal? I believe adjuvant chemotherapy or neoadjuvant in patients with hepatic dysfunction. Can you give doxorubicin and docetaxel? Can one of the medical oncologists take that question, either Jack or Susan or somebody from Cesar? The question is, what chemotherapy do you give in the presence of hepatic dysfunction?
Paul, yeah, this is Jack. I think there is a clear need for adjuvant treatment, and I am concerned about the recommendation not to proceed. I wonder if it is clear whether viral hepatitis has been ruled out. There have been clearly fatal cases of reactivation hepatitis B with adjuvant breast chemotherapy without clearly ruling out hepatitis B or prophylaxing. After reading this case, if the liver tests were as they are presented and did not come down, I would feel that one possibility might be to start with paclitaxel and trastuzumab weekly, possibly adding in pertuzumab if it were available in this case, and further evaluating the liver. But most certainly, hepatitis B absolutely needs to be ruled out before proceeding, otherwise there could be dramatic complication.
Any other comments? Susan?
Yeah, so as I read this case, this is clearly a very high-risk woman, and she was only screened with a hepatic ultrasound, so I think I would start with, am I sure that she does not have diffuse involvement of the liver, which can look like this? So I think the options would be to, if you have other modalities of screening, such as an MRI or a CT of the liver, or even a liver biopsy, just to see what's going on. If we assume that this is hepatitis unspecified because she did have B and C testing that was negative, I think Dr. Urban's recommendation to start with paclitaxel and trastuzumab would be what we would normally recommend. If you dose your paclitaxel weekly, you should be able to control for possible side effects. So I think that would be the best approach because this woman is clearly at high risk for death from her breast cancer. So I would not want to withhold adjuvant treatment at this time. But I think it would be important for me to exclude that she does not have metastatic.
Thank you. So there's a radiation question here, and that is, can radiation be given with trastuzumab first before a workup and diagnosis of transaminitis, while waiting for the workup and diagnosis? So who feels that radiation can go first? Again, Susan, speak up.
So again, I believe this woman's greatest risk is her systemic risk and death from breast cancer. So I would not be so concerned about the local issues right now, and I would try to work diligently with the gastroenterologist to get this woman started on treatment as quickly as possible, systemic treatment.
Right. Any other opinions about that, Cesar?
Just to echo that, I think it's really important to work closely with gastroenterology and understanding the etiology of her hepatitis. If it's concern for autoimmune, just strong treatment with steroids or whatnot. But yeah, just a close collaboration with hepatology and working this up.
Janine messaged me. She's having a problem with her connection.
Thank you very much, everybody. We're still having a bit of problem connecting to our presenter, first case, and I want to welcome Dr. Wiesel from the City of Hope. Hi, Dr. Wiesel. Thanks for joining. The first case, which is where we really need you, is Janine, can you hear us now?
Yes. Hello.
Hello. Janine, we have presented the second case, so if you are ready, you can present your first case of the day, which would be nice.
She just disconnected, actually.
Oh, she's gone. Okay, well, let's move to the third case, please. And that was... Okay, Janine, whenever you're ready, can you present your case if you're ready, Janine?
Yes.
Thank you. You can start whenever you're ready, and we'll just share the slides first.
Okay. The patient in case...
Sorry, wait for Dr. Shavari to present the first case, please.
Yes, we are here presenting. Dr. Carlos Molina will present it.
Okay.
Okay. The patient in this case is a 68-year-old woman. Her family history is relevant for the following reasons. Her grandfather died of lung cancer at age 78. Her grandmother also died of cervical cancer at age 65. Her father died of pancreatic cancer at 78, and she has 3 siblings who have been diagnosed with thyroid cancer, and also one brother with multiple endocrine neoplasia syndrome, and also she has one son with thyroid cancer. Her gynecologic antecedents are her menarche was at 8 years old. She's gravid at 6, para 3. She has had 3 cesarean sections. Her last menstrual period was in 1995 when she was 47 years old, and she has used hormone replacement therapy for 2 years. Her medical history is also relevant for obesity, mixed dyslipidemia, fibromyalgia, and hypertension, all of which are currently under medical treatment. She has had some history of some cancers. In 1995, she was diagnosed with a papillary thyroid cancer, which was stage 3. It was managed with total thyroidectomy and cervical lymph node dissection, and she also received radioactive iodine. In 2001, she was diagnosed with a basocellular carcinoma on the left eyebrow. It was surgically managed. In year 2012, she had an endometrial carcinoma, which was stage 1A. It was a grade 2, and it was also surgically managed with a hysterectomy and bilateral salpingo-oophorectomy. And in the year 2013, she was diagnosed with kidney cancer. It was conventional clear cell tumors. The tumor size was T1B, and it was an intermediate risk. It was managed surgically with a partial nephrectomy. At the moment, the patient is asymptomatic, and the history of the present illness is as follows. In the second quarter of 2015, she was referred to genetics by internal medicine because of the suspicion of a familial cancer syndrome, given her antecedents. The probable diagnosis given was Cowden syndrome. The genetic tests are currently not available, and it was considered that she fulfilled 2 major criteria and 1 minor criteria according to the international Cowden consensus. In the first quarter of 2015, she had a mammography performed, which was BRATS2, and in the first quarter also, she had a CT scan as part of her follow-up without any suspicious lesions. Colonoscopy is still pending. So the diagnosis of the patient is Cowden syndrome, and the recommendation given by the Service of Oncology was to perform a surgery, specifically prophylactic bilateral mastectomy. And the Service of Surgical Oncology did not agree and only considered surveillance.
So our first question is, can we consider her to have Cowden syndrome even we don't have the test available?
So this is, let me just go to Dr. Wiesel. I'd like to introduce Dr. Jeffrey Wiesel. Can you hear at me, Dr. Wiesel? Just if you unmute your microphone, just unmute your microphone, please. We still can't hear you. We have no volume. Just on the top toolbar, there's a microphone. If you just cancel that. Nope.
What you can do is, Dr. Whitesell, on the top toolbar, you'll see a gear wheel. If you click that, you can select your microphone. So you should select whatever device is your set of earbuds.
While we're waiting, does anybody from medical oncology want to speak up, or anybody?
Yes, we can
Let's
hear you
go to
now.
Dr. Wiesel.
Okay, great. Yeah, something for some reason the head's not working
So
properly. There we go.
Sorry, I hope you could see. Welcome, by the way. I would like to welcome you to our tumor board. Dr. Wiesel is from the City of Hope in California. Dr. Wiesel, you heard the history, the strong family history, and the personal history in this patient. And there's a presumptive diagnosis without genetic testing of Cowden syndrome. And there's been a recommendation, at least from one surgical team, that based on that, the 68-year-old patient should have bilateral preventative mastectomy. And the question from Mexico City is, do you believe the diagnosis, and is that a reasonable, what's her risk now that she's 68 and hasn't had breast cancer, and how should the medical team proceed?
Yeah. So first, it's an extraordinary family. Just from the perspective of the SIBSHIP and all the thyroid cancers, we can return to the question of MEN in one of the siblings because that's clearly a genetic issue. First, I don't believe that the patient actually meets Cowden's criteria. as presented. So that's a critical first step. The management issue, of course, is another entirely, even if we believe that. Obviously, it'd be ideal to have genetic testing available. That's one of the hallmarks. But when you look at the new NCCN criteria, the 2016 criteria, in order to count it as a diagnostic criteria for Cowden's as compared to testing criteria, you really need at least one of the major criteria to be macrocephaly, or Lermette du Clos, or one of the trichomomas, one of the specific skin lesions. Yes, sir.
Can I just interrupt by reading to you what one of our doctors who's not here, Dr. Ellison, said? Given that the brother is known to have MEN, it seems that would be a more likely explanation for the other thyroid cancers in this family rather than Cowden's. So he's agreeing with you, doctor. Also, in the clinic, we screen by head circumference, which is a relatively sensitive indicator of Cowden's. I agree with you that at her age, it is unclear she has particularly high breast cancer risk given the lack of clarity regarding a genetic syndrome. And of course, too bad she can't get multi-gene panel testing. That's from our lab, people.
Yeah. So exactly. I think the macrocephaly is simple to do. You really need to see a head circumference of at least 58.5 centimeters. I've never seen a Cowden's that wasn't closer to 60. So that's actually, even without a genetic test, if she had macrocephaly in addition to some of these other findings, I might accept the diagnosis. The kidney cancer is a minor criteria rather than major, and I'm not even certain about renal cancers in that syndrome. But even if we accepted that she were Cowden's syndrome, the risk for breast cancer is between 25 and perhaps 50% or 60%. Some of the earlier estimates from Dr. Karasing's group, which were a high-risk cohort, put it at closer to 70, but I don't accept 80% either way. And even if it was a BRCA carrier at 68, I would offer her surveillance in lieu of risk reduction surgery, given the age-specific risks, the annualized risks. Again, even if I accepted a genetic diagnosis, the annualized risks are perhaps no more than 1.5% at best. It's probably much lower than that in her. So I think really the certainty about the diagnosis is important. And by the way, papillary thyroid cancer is less common than follicular, at least in Cowden's syndrome. So even the type of papillary cancer or of thyroid cancer is atypical. So again, I think clarity of the diagnosis is important.
Thank you very much. So we had, Janine, would you like to comment? One of your surgical teams proposed bilateral mastectomy, another one said observation. Would you like to tell us what's happened to the patient?
The patient actually is under observation with the routine mammography.
So it seems to me that what Dr. Wiesel has described is a very simple clinical test. Measure the size of her head, of her skull, and if it's 60 centimeters or above, that increases the suspicion of a Cowden's. But if it's normal, it reduces it tremendously, or rules it out. Dr. Wiesel, does it rule it out?
Well, I think they mentioned a few things. She had uterine cancer. She didn't have fibroids. There are no other pathognomonic lesions, at least in the case. So I think it would certainly become close to ruling it out, given the circumstance. So if she had a normal head size, which, by the way, would be about 55 centimeters, I would essentially... Oh, the other thing to do is to look at the mouth. That's a very simple maneuver. And I should have loaded up a picture of a tongue for you, because they're very simple to look at, obviously. It doesn't cost anything. And they're often definitive in terms of very, very accentuated papillations, if not submucosal nodules. So even without a genetic test, macrocephaly and nodularity of the tongue. The other thing is the thyroid universally has thyroid nodules in the context of the cancer. So they almost all have a multinodular goiter that I've found many times coming from a surgeon who said the thyroid was normal. I've found many nodules because they usually aren't focused on the thyroid. But either way, it's often a multinodular goiter, which might even be evident from pathology.
So I will say that for her, the clinical consideration with or without Cowden syndrome will be the same, but not for for the rest of the family, right? So it will be nice to have a head image and a clinical examination by dermatology and the mouth specialist.
Yeah, so just head circumference, a tape measure. In our course, and we give everybody a tape measure when they leave. So one of our big gifts.
Okay, great. Thank you.
Dr. Wiesel, is this a reasonable time? Because I've used your name so frequently on these tumor boards, would it be fair to ask you to give a brief description of your research study with Latino founder mutations of BRCA1/2 in South America? Because we have a lot of people online interested from South America or from elsewhere who don't have genetic testing available.
Yeah, well, I'd be delighted to, and it's an honor to be invited. By the way, I've been waiting to meet you for some time. I also wanted to give a quick shout out to Jack Urban and Susan Sager, both of whom were colleagues of mine at Tufts University when I was there for 10 years. So Jack and I were actually fellow mates before he went on to great fame there. So I've been working on Latino issues for over a decade now, primarily because of what we have in our own backyard, which is I've been working at the county hospital running a pro bono clinic. 89% of the population was Mexican American. By way of doing our own diagnostic testing, we had to get testing done because Medicaid didn't cover it here. We had the same disparities to start with. We started to identify mutations that were not simply spread across the entirety of the gene, but that were recurrent. We identified for the first time that 185-DELAG was a mutation that was known to be in Jews, but also was in the Mexicans, and it happened to have the same haplotype. Why? Probably the Spanish Inquisition and the diaspora into the New World would explain that, but it shared the same haplotype as my West LA Jews. Second, we found a mutation in 2007 that turned out to be a founder in Mexico. This particular mutation, we believe, is about 10% of all BRCA1 positives, and BRCA sequencing is not complete without sequencing and rearrangement studies, so I believe it was underrepresented even in Tom Walsh's study of a number of years ago where they looked at large rearrangements. They only had 19 Hispanics in their entire study, so that's less possible. So it turns out we have a situation where there were certain mutations that were frequent among Latinos, and so we designed a very low-cost test. In fact, it's a 100-mutation test on a sequenome platform that costs about $20. So you have two issues. One is the availability of trained genetic risk assessment personnel, and second, the tools in order to apply that trade in order to realize the benefits of prevention. So a lot of our work now is related to training individuals in Latin America to do cancer risk counseling. We engage them in our 100-hour course here at the City of Hope, and then we go down and we give them, we get them engaged in our registry. Therefore, we're able to judge the local cancer epidemiology as well as judge the outcomes of the clinical work. And we've been working now with INCAN in Mexico City, the National Cancer Institute there, University of Guadalajara, Monterrey, we're in Lima, Bogota, and a good friend, Patricia Prola, in Porto Alegre. So Yanin is actually coming to spend some time at the City of Hope, which we're very excited about, where she'll be doing some direct training in this realm. But the core, basically, we've designed ways. I know that colored genomics, for example, will do a multi-gene panel for $349. We've got BRCA sequencing down to $73 for clinical grade sequencing. So we're applying the tools so that they can practice the way they need to. We go down and proctor what they do as well, and it's one of the things we noticed at INCAN was they created a high-risk clinic just to take care of their high-risk patients, and they found out that one of the surgeons put their hand up and said, I can only do 2 extra mastectomies a month. So there are many supply issues down there as well, but this is the only way we're going to get there is to catalyze their work. So
can I ask a million-dollar question? Is it still possible for people in South America to send blood testing to your laboratory for genetic testing for a price, or how does it work?
We don't believe in just testing, but rather we train. So if there's individuals or groups that want to get engaged and create a genetic cancer risk counseling program, we'd be honored to have them in our course. It's R25E, supported by the NCI. We put global into the title for a purpose. So we are actively, they need to have English capability. We're hoping to create a Spanish version of the course. But the goal is to train, then they can engage in the registry and the collaboration. I'm supported by the Breast Cancer Research Foundation as well, and we'd be delighted to do this, but we're not selling it. It's not a CLIA test, but CLIA doesn't exist in Mexico or South America. So we're giving them clinical grade testing, encouraging them to get commercial confirmation, just because that's what I would do here. That's really where we are. But we are more than happy to have additional collaborators.
I have a very large number of doctors in South America who present cases that require testing or counseling, both. Are we at liberty to distribute your email address to those doctors and let them approach you for what should be done?
Absolutely. We've trained about 15 people in Brazil now. I think we're close to a dozen in Mexico, and we'll be delighted to increase those numbers, and even on a case-by-case basis. We've also created I really like your interface. We do a web conference tumor board every Wednesday that actually has many international participants as well. So I've been looking forward to meeting you, just so we could, I think we have some symbiotic things going on that would be very helpful to align.
Well, thank you very much. That's very helpful. I think I'm going to give a chance to the third presenter, the third case today, if we can move on. And let me just find it on my sheet here. The third patient is going to be presented from Sofia, from Dr. Valev. Dr. Valev, can you hear me? Thank you. You can unmute your microphone, and when you're ready, Jessica's going to share the slides, and you can go ahead and present your case, please.
Okay. Okay, so hello everyone. This is our case from Sofia. It is about a 38-year-old premenopausal patient that presented in our clinic after having undergone a radical surgery for breast cancer. During the last quarter of 2014, she performed a lumpectomy with axillary lymph node dissection, and the tumor stage was T2N0M0. Histology was high-grade invasive ductal carcinoma, and immunohistochemistry was ER positive, ORAD score 8, and PR negative. HER2 was 1+, so it was negative. She has no family history of cancer. And during the diagnosis, patient was pregnant. It was her first trimester. It was gestation with 10, and it was her first pregnancy after in vitro fertilization. Unfortunately, the patient was counseled to terminate pregnancy, so surgery followed by chemotherapy and radiotherapy could be given. After surgery, before the start of chemotherapy, she had an ovarian tissue cryopreservation. Okay, so at the beginning of 2015, she started her adjuvant chemotherapy, and she did 3 cycles of FAT90 that were followed by 3 cycles of docetaxel. She had no major toxicities, and LH-RH agonist was started before chemotherapy to preserve ovarian function, and then she received radiotherapy for her breast cancer, and third quarter of 2015 she began adjuvant hormonal treatment with LH-RH agonist and tamoxifen. 20 months after surgery, patient decided to try another in vitro procedure. Overall, this is our case. I think it presents several challenges and concerns certain questions that probably we don't have data, or we have well, maybe insufficient data, or maybe we have confronting data. So I would like to ask these questions. The first one is, are in vitro fertilization procedures linked to increased breast cancer risk? Do we have any data there?
Let's discuss the questions one at a time, if you don't mind.
Okay. All right.
So we'll open the discussion for that first question. The first question, does in vitro fertilization increase the risk of breast cancer? Who would like to volunteer to speak on that subject?
This is Seema Khan from Chicago.
Yeah, thanks, Seema. Thank you.
So I think in terms of risk of recurrence, we don't have specific data about in vitro fertilization to my knowledge, but I think it's very clear from multiple studies that pregnancy in and of itself doesn't increase risk of recurrence. The data about in vitro fertilization have focused more on primary incidence, and I think the fears about incidence of breast cancer and risk of primary disease related to in vitro fertilization have been largely laid to rest. There have been several large studies and a meta-analysis recently, and the only possible area of doubt might be women who have multiple cycles. But even so, it's not a very strong connection, and so for a young woman who had to give up her first pregnancy in order for her treatment, if she were highly motivated to pursue a second one, I don't think we can advise her that there's any firm reason to worry about increasing risk of recurrence.
And that's irrespective, as you said, a meta-analysis, irrespective of the type of in vitro fertilization stimulation that's used on the patient, ovarian stimulation that's used on the patient. Seema, do you want to comment on that? Was that with all types of in vitro stimulation, I mean of previous stimulation of the patient? Seema, does anybody else want to comment? Because I think Seema's just frozen at the moment. Mm-hmm. Does anybody else, Jack or Susan, do you want to comment on?
Yeah, I think it is independent. I also think that the bigger hormonal exposure, of course, is the pregnancy itself. And I think, as Seema mentioned, there's no evidence that the pregnancy per se will have an adverse outcome. That said, I think the major consideration is in order to proceed to this, one has to stop hormonal therapy prematurely that could be life-saving. And I think that's the bigger discussion, which is to short the appropriate hormonal therapy that may, in this case, be life-saving. Obviously, it's a personal decision, but I don't think the type of IVF or the pregnancy itself has that data to show that it will affect the outcome once that decision is made.
Do you concur, Susan?
Yeah, so again, there's limited data, but to the best of our knowledge, there's no increased risk with breast cancer with in vitro fertilization procedures. The other thing of interest in this case, and I was surprised at the association, but I didn't find any impact of the decision to terminate a pregnancy with regard to prognosis. The prognosis looked the same stage by stage. So I think intuitively you'd say, well, maybe because this was hormone receptor positive, she elected to terminate, maybe she'd do better. But that's not what the data shows. Not that it's great data, but it's out there. So I think, you know, for this patient, my big concern right now would be her tamoxifen exposure, and I would certainly want her to stop her tamoxifen and be off it for a minimum of 3 months to prevent birth defects with that drug. So I couldn't tell from the presenter how long she had been off her endocrine therapy before she began to go through her in vitro fertilization again.
Do we have an answer to that question from Bulgaria?
Yes, she was 3 months off tamoxifen, yes, for the fear of birth defects. Yeah.
So the second question, do you want to ask the second question?
Yep.
Can you share the part?
So the second question was, Well, was it possible for the patient to safely carry first pregnancy to term? And what neoadjuvant chemotherapy would be safe, and when should it be administered?
So I think the answer to that is yes, it is safe to carry pregnancy to term. I think there's been ample long-term data with cyclophosphamide and anthracycline in pregnancy, provided that it is started after the first trimester. And so in this case, she was 10 weeks pregnant. One could have waited until, say, second trimester, administered anthracycline and cyclophosphamide after surgery, and then delivered the baby and proceeded with other treatment following. There's less data on taxanes, and I think the number of case reports is less than 50 with taxanes, and I would be somewhat uncomfortable about delivering a taxane during pregnancy. And there's definite evidence of a contraindication to trastuzumab, given the incidence of oligohydramnios mainly, not birth defects, but difficulty with amniotic fluid production. So I do think there would have been a way to deliver a safe and effective adjuvant treatment or neoadjuvant treatment, deliver the baby and continue following the delivery.
Cesar, do you want to say something, or Alphonse wants to say something?
Yeah, I would just say, if waiting until the second trimester, depending on the anthracycline-based regimen administered, you'd still have probably a pregnancy in the weeks 20. So, I think it still probably would be a higher risk, situation, but something to work closely with the obstetricians.
Can I follow up the fourth question? Stay on the line, Cesar, because the fourth question. Sorry, Alphonse wanted to say something.
Yeah, just a quick comment on the radiation part. While you could do surgery or chemotherapy during pregnancy, radiation, of course, is out of the question. It has to be after the pregnancy. Even if you try to do any protection system for the patient, there is always the scattered radiation from the breast, and who knows how far it goes down. So radiation is out of the question. And the other thing is that assume you have a patient who doesn't need chemotherapy at all. So she can have lumpectomy, and you could wait up to 4 months based on some Canadian data, and then the patient can deliver, and then you could give your radiation. The risk of local failure will not increase. Even if you wait a little bit more, the risk of local failure will increase really very little. That's in case if the patient would like to pursue her pregnancy.
Thanks. And the fourth question, maybe go back to you, Cesar. I think we've partly answered this question already. Does pregnancy influence the risk of progression in hormone-sensitive breast cancer in general?
Again, I don't think the pregnancy itself would increase the risk, but the conversation to have with the patient will be the time off her anti-hormone medication and just weighing the pros and cons of her specific risks.
Anybody else on the pregnancy breast cancer? Yes, Susan, please.
So I had a second comment as well. So in terms of the sequencing of chemotherapy for patients who need chemotherapy while they're pregnant, typically we've done the AC or an anthracycline-based treatment every 3 weeks without growth factor, trying to kind of nurse that patient through their pregnancy with chemotherapy. There is some data using paclitaxel late in pregnancy, and we've done that in a number of cases at MGH without adverse outcomes. So I think for very high-risk patients, we can support them through the second and third trimester with chemotherapy. In terms of the influence of pregnancy, I think we're all aware that initially with any woman who is pregnant in that first year postpartum, there is a higher risk of de novo breast cancer, and after that the breast tissue seems to mature and the risk of breast cancer is less. But for this patient, I think there's no particular concern.
Right, thank you. And the final question, if we can just go back to the slide, Jessica. The question really is how long an interval should be waited. How long should the patient wait for between her breast cancer surgery and a new pregnancy? So that's also been partly answered, I think. But anyone want to speak to that?
I'm sorry. Go ahead, Susan.
Okay, so I guess in terms of thinking about this case, she was quite young, 38. We didn't particularly talk about her family history, but you know, she would be a gal we would normally think about genetic testing for, with the thought of how long would we want to delay pregnancy. So in general, I try and wait at least 2 years, but again, that's part of the discussion with the patient and her significant other. If you knew she had a BRCA1 or 2 mutation, you know, you wouldn't want her to wait 5 years. You'd be saying, well, let's have that child and then think about surgery for her ovaries, you know, by age 40-ish. So, you know, it's always more complicated.
Any other perspectives?
I was just going to add that, you know, she's 38. She's a T2 grade 3 invasive cancer. Clearly, her risk of recurrence is meaningful. And how long to wait, in my mind, largely relates to her willingness to accept adequate early adjuvant treatment. I think certainly less than 5 years is going to put her at significant risk in the early going, mainly because of the grade of her tumor and the lack of adequate adjuvant therapy. That said, she doesn't have a long time to be able to wait. And as long as she's really clearly understanding the best estimate of risk of recurrence by not having adjuvant treatment, I think there's no ideal time. She's going to have a substantial risk even after 5 years of recurrence, not excessive, but high enough that there's still going to be a risk there.
Those are great remarks, Jack. So we've learned a lot from these very important questions. Thank you very much from Sophia. First of all, the consensus is there is no increased risk of breast cancer related to in vitro fertilization procedures. The second question, which I'm going to push the medical oncologist a bit about, Jack showed reservation about using taxanes, I think, in the pregnancy setting. Susan did not. Am I correct? And where do we stand on that? Because that's a very important question for everybody on this call, I think. So, Susan, can you defend the use of taxanes again, please? And Cesar, can you comment on that, please? From Northwestern.
Yeah, you know, I'm not aware of the strength of the data for use of taxanes in pregnancy. I think, you know, obviously we'd like to have some more data regarding its safety. I'm more aware of the anthracycline and cyclophosphamide use.
Susan, do you want to say something further?
Yeah, so I can look up the reference because we reviewed this at conference a couple months ago when we had an even higher risk patient, a patient with node-positive disease. So I can check the reference and circulate it after conference.
That would be very helpful. So we will circulate the references on the use of taxanes in pregnancy to everybody on this call, viewers and participants, after our tumor board is finished. And then, does pregnancy influence the risk of progression? I think the answer to that was no, and I think there was consensus on that. So I think we answered all the questions. And does anybody have any other perspectives on any of the cases to offer? We just missed one radiation question, Alphonse, when you were out of the room. It was on the first patient. I think
I saw that.
Yeah, so do you want to comment on that, or can you?
The patient who had the liver function.
That's right. Yeah,
it was a question whether we can give radiation before chemotherapy. Well, in fact, yes. We used to do this many years ago, but there was a randomized trial from the Dana-Farber and the Brigham comparing patients receiving, after surgery, receiving radiation followed by chemo or chemo followed by radiation. And at the end, both of them gave a similar result, with the exception that patients who had positive margins and started with chemotherapy had a higher local failure rate. But nowadays, we really don't leave patients with positive margins, because this trial, which was published in the New England Journal of Medicine by A. Brecht, maybe 15 or 20 years ago. So it's an old trial. But if you have the circumstances that you need to delay chemo for whatever reason, you could always start with the radiation and then you give the chemo after that. But overall, the consensus is like the chemo comes before radiation, but there is no negative impact of starting with radiation and then give the chemotherapy after that.
I think that was the question from Manila, the case, the case that we presented from Manila. Can we give the radiation first? Thank you, Alphonse. Does anybody else have a comment about these very important cases, the genetic case? Yes, Susan.
So I don't see that Dr. Weitzel is still on the line, but as I read the Cowden's case, the other syndrome I thought about was, could this family have Lynch syndrome and this patient just have a sporadic breast cancer? So I think the use of the multi-gene panels has been, practice changing for all of us here in the U.S. that have access to the panels. So I think for that particular family to really ask the question about colon polyps, colon cancer, maybe that would be helpful. And then, again, back to that Cowden's family, the current NCCN guidelines for patients who do indeed have Cowden syndrome or P10 mutation is to consider for high-risk screening both mammograms once a year and breast MRIs once a year. And so, I think we accept the risk for these patients and need to follow that very carefully. So again, in the U.S., we would routinely add breast MRIs. I don't know if they're available to you in Mexico. Yes, I'm seeing shaking. Okay. So that would be the other thing. And I think you could say at age 68, is that necessary? If you believe that's what she has, I would do it, as long as her health is good.
I think I was a little bit surprised when Dr. Weisel said that at 68, having not had breast cancer, her residual risk, lifetime risk, was actually quite low, and observation was better than surgery in that case. Would you agree with that, Susan?
I'm sorry, Paul, I missed your question.
Sorry, the question is, Dr. Weisel pointed out that this patient is 68 and has not had breast cancer, so that irrespective of whether she was a BRCA carrier or Cowden's or anything else, her residual risk was sufficiently low to justify observation. Would you agree with that?
Yeah, so I think if you look at the BRCA1 and 2 data, which is the strongest data we have available, your age of diagnosis of your first cancer really sets your future risk of a subsequent cancer. So if you have two women with a BRCA2 mutation, one is diagnosed at age 35 and another at 65, their subsequent risk of breast cancer is very different, much lower the older you get. And the way I tell patients about this is, we've only tested you for a certain gene. We're not able to test your life influences in terms of cancer risk or any protective genes that patient or family may have. So
is that late occurrence of CANTIN1 carrier transmitted to the family member subsequently as well?
Well, I don't know that we know that exactly, but in general, as you're doing genetic counseling and genetic testing, you look at the flavor of the family. So, one family that has a lot of young age of diagnosis with one gene mutation and the same gene mutation, a different family with late onset, you feel like they have different risks.
Right.
But it's hard to quantitate that.
It's extraordinary, actually. I once followed a family, off topic here, with familial testicular cancer. 5 brothers in one family had testicular cancer. 4 of them were diagnosed at the age of 36. 4 brothers were diagnosed at 36 with primary testicular cancer. So there obviously is some circumstances where genetic risk, age at presentation, is transmitted. Does anybody want to comment on that point or any other point? We have finished a little bit early on this tumor board, so thank you very much to the presenters. Thank you, Yanin, for getting connected from Mexico City, and from Sofia and Manila late at night. Thank you very much, Herdy, and thank you to all the panelists for joining us and for your lively conversation. Thank you very much. We're going to disconnect now. Thank you.